Good morning, good afternoon, good evening. Welcome from wherever you're joining us today. Thank you for being here. If it's your first time with us at a webinar hosted by Women's Health Advocates, a big welcome, a warm welcome, and thank you for coming. So my name is Hanafi. I'm one of the co-founders of Women's Health Advocates, co-leaders with Liz and team. And I'm also a co-founder of MedTech Strategy Advisors, and I work in the regulatory science world, helping founders figure out what the evidence they need to collect to support getting technologies, medical devices to the patients that can benefit from them, and centering around patient needs and centering around our unique needs as women. So Women's Health Advocates is focused on educating policymakers, lawmakers, decision leaders on the unique needs that impact women throughout our lifespan. Women's health is defined as diseases or conditions that distinctly, i.e. uniquely, differentially, or disproportionately impact women throughout our lifespan. And we make up 51% of the population. We are the chief clinical officers and the key decision makers when it comes to healthcare. And we're also the largest consumers of healthcare as well. So we need to make sure that healthcare centers around our needs, and especially when it comes to Black women's health needs, where historically we've been, our needs haven't been accounted for. And that's why we're really excited. It's Black History Month. We're here to talk about how we can center and elevate and ensure that Black women receive the healthcare they need and have better health and better healthcare outcomes. I'm going to start the quote with one of my favorite activists in this space, and it's Dr. Martin Luther King. And this one says, "If I cannot do great things, I can do small things in a great way." And that is what these folks are doing here. They're bringing their lived experience, they're bringing their leadership to the table, and collectively we're working to elevate our voices and our needs. So I thank you for your time, and I'm really excited to actually turn it over to Erinkate Peart, who has recently joined our steering committee and is going to be leading and moderating this panel. No, she actually doesn't come from a healthcare background. She comes from the finance background. So this group is here to bring all women with lived experiences and expertise to the table and make sure that we're inclusive in the efforts we're putting forward. So Kate, over to you, and looking forward to the dialogue.
Thank you so much, Nada. And yes, I'm a recent joiner to the steering committee of Women's Health Advocates. I joined shortly after the recent incidents that we witnessed in North Texas and in Indiana, where Black women were being denied while they were giving birth. And as you know, if you guys have been following the news, there's been legislation introduced into Congress called the Wells Act by Representative Robin Kelly that is trying to address those issues. And I personally have lived experience in that area when I gave birth to my daughter, my first child, where I had a very difficult labor experience. And so those experiences triggered me late last year, and that caused me to join after attending the retreat at the end of the year. And so again, good morning to everyone, and good afternoon, wherever you're calling from, for joining today's event. I am honored and privileged to moderate this powerful panel with these awesome trailblazers in honoring Black History Month. My name is Erinkate Peart, like what Nada just said. I'm the founder of Ekcell Enterprises, which is a management consulting firm that specializes in strategic advisory and leading transformation programs and fractional COO services. My firm also offers executive coaching opportunities for individuals. And I'm located in New York City with my family. And if I have to add another interesting fact, I'm obsessed with playing Mahjong. I picked up that hobby 2 years ago with friends, and I just can't help playing it all the time. If there's fellow Mahjongers in the chat, please make yourselves, this is your coming out party. I'd like to know if there's more people in New York that I can play with.
So with that, my mom. You need to meet my mom. She's like,
yes. Okay. Well, your mom. Okay, I'm playing. Yes. That's there, Beth. We're joining. In New Jersey, and so I'm gonna recruit you, Beth. You need.
I have no clue, but she is an expert. So
Oh my gosh.
I love it.
And so with that, I'd like each panelist to just spend a couple of minutes introducing themselves. And with that, Dr. Beth Garner, if you could do us the honor and pleasure of introducing yourself.
Of course, yes. Thank you so much. And this is going to be fun. So, Beth Garner, I'm a women's health physician by training. Going even back to that, I was born and raised in Nigeria, and I know there's some other people of color from Africa on this, so this is great. I after about 4 years going into treating patients, which I loved. I felt that I couldn't have enough impact by taking care of one patient at a time. So I decided ultimately to go into industry. I've been on the industry side for about 18 years now. Been very lucky to just stay all of that time in women's health. So it's all I do, all I've ever done. And currently I'm the CEO now of a small startup that is developing therapies for PCOS. Liz always tells me that I need to also mention that I have been the past president of the American Medical Women's Association as well, and a founder of Women's Health Advocates. Thanks.
And a fun fact that you wish to share?
I have a granddaughter and a grandson about to be born in a few months.
Oh, wow. Congratulations. That's wonderful. All right. Can we have Dr. Irene Aninye introduce themselves, please?
Hey, well, thank you so much for having me. As you mentioned, my name is Dr. Irene Aninye. I am the principal and founder of Wellco Solutions. My training is in reproductive endocrinology and metabolism research, and I've spent many years in translational science with an emphasis on women's health and healthcare policy. And so taking all of my experience across the different sectors, I now partner through Wellco with academic and health-focused organizations to address persistent research and care gaps and increase their capacity to action real sustainable solutions. And so I say all that to say that I am Washington, D.C. based, but today I am dialing in off the coast of South America because this event and program was so important that I really wanted to answer that call. And so Black women's health, I always say is, shouldn't just be, it should really be women's health, and women's health really should just be health, but it is not. And so we are here today. And so hopefully, I can add some insights to this conversation, both personal and professional, from my perspective. And so I'm a scientist, I'm a Black woman, I'm a patient, I'm a caregiver, and I'm here to discuss and share. So thank you for having me.
Thank you so much, Irene. Where in South America are you located right now?
I'm just off the coast in Curacao.
Oh, wonderful. Yeah. All right, thank you for joining us. All right, I'd like to have Dr. Natasha Fievre introduce herself, please.
Aloha. I am dialing in from Honolulu. My name is Dr. Natasha Fievre. I am an attending physician at the Brooklyn Hospital Center in the Department of Obstetrics and Gynecology. And I also serve as the Director of Outpatient Women's Health Services. So I work closely with the residents as well as the medical students in their training in the Department of OB-GYN. And also I continue to operate, have my own patients, and just serving the community any which way that I can. So fun fact, I'm actually in Hawaii because I love to salsa dance. So I am here for a salsa congress for the next 5 days.
Awesome, awesome. Fabulous. Thank you for taking the time out from your free time. This just shows your level of dedication. So we appreciate it. Thank you so much, Natasha.
My pleasure. Happy to be here.
All right. And last but not least, we'll have Dr. Ifeoma Udoh.
It is a pleasure to be here with you all this morning. It's still morning time for me, so I'm with you, Natasha. I'm in California. I'm in the Bay Area, so it's starting out the day. I ran back in here after dropping my kid off at school. I was like, I got to get there. So it's a pleasure to be here with everyone in this brilliant panel of women. My name is Dr. Ifeoma Udoh. I'm the Executive Vice President for Policy and Research at the Black Women's Health Imperative. The Black Women's Health Imperative is one of the oldest organizations in the United States that is fully dedicated to the policy, the practice, the implementation, and the well-being of this country's 21 million Black women and girls. Founded on the college campus, Spelman College, traditional HBCU. We love Spelman. And founded by our esteemed founder, Billy Avery. In my role as the lead at BWHI, I really come to this lens of policy from a scientific background. Policy should be driven by science. It seems like it should be really factual and that the things that we do in this country, particularly around women's health, should be driven by what we know are the existing disparities in women's health, of which there are many. I am a scientist by training. I'm a medical anthropologist. I come to this lens from the perspective of thinking about public health from a stories background. What does community say? What are our stories? Stories are data. And I also think about data translation in terms of how we take what we know from those stories and what we know from data and translate that into policy practice. So it's a pleasure to be here on this panel celebrating Black History Month with fellow Nigerians. Beth Garner, I am first generation Nigerian. I was born here in the States, but my parents are both Nigerian, they're Igbo. So it was wonderful to hear that tidbit of knowledge from you. And I guess a fun fact about me is tying in all the stories that I've heard today is that I'm a surfer. So I'm actually really jealous of Natasha right now because you're in one of my very favorite states, parts of the world to surf in. I take my daughter, I have a 9-year-old daughter, I'm a single mom, I have a 9-year-old daughter, and we go on one surfing trip every year. And you were in one of my favorite parts of the world to surf in. So this Nigerian connection, this Hawaii connection, all of these things are making so much sense for me to be here. So it's a pleasure. So
that's fabulous. I wish I could surf. I'm so impressed. But thank you for sharing that. So let's just jump right into it. So the name of the program, today's program is, Advancing Black Women's Health. And if you think about that overarching theme, I'd like to just start off with a round robin question around, each of your thoughts when it comes to that. And so when we talk about advancing Black women's health, what does that phrase mean to you personally? And why does this work feel urgent right now?
I can start. For me, in the area that I work in, Black women are 3 times more likely to die in childbirth. And that's because their symptoms are ignored. Their needs are ignored. They don't have access to the best care. And so this is a time in which we need to all band together in all areas, push and move forward to change that narrative, because there's no reason why in this country that we live in that women should be having, subpar care. Everyone should be on that even plane when it comes to getting the best care, especially during the time of pregnancy.
I can add to that as well. Some other numbers, I guess, I think, talking about the numbers really, to me, shines a light. So, you just mentioned, Black women, 3 times more likely to die. And 80% of those deaths are mostly preventable, which is just awful, right?
Yeah.
I think, we think about in the US, about a third of counties in the US are what we call maternity deserts that have basically no maternity. And a lot of that is in areas, obviously, not surprisingly, in areas where there are women of color. I think just one more piece of data around, I think 21%, somewhere around that, of Black mothers who go into the hospitals, for childbirth. About 21% will say they had poor treatment, due to their ethnicity, cultural background, et cetera. So there are just so many issues that we need to deal with. And, I think over the years, I like I said, I came to industry in 18 years ago, and what's so awful for me to see is that pretty much nothing has changed over that time.
Yeah, Dr. Gardner, I diving in on that. Nothing has changed over time, and yet things have, but it feels like we've gotten to this crossroads. And I think when I think about why advancing women's health is such a public health urgency right now, it's always been.
Yeah.
why it's such a public health urgency right now.
Yeah.
As Nada noticed and said at the beginning, we make up 51% of this population. We are an aging population. So in the United States, not just Black women and women as a whole, but the United States is an aging population. It also means that women will bear the brunt of what that means in terms of being caretakers, being sandwiched between raising our children and taking care of our mothers and fathers, and being caught in this sort of economic ecosystem where we are not supported by the policies and systems that need to be in place to ensure that for our families. And then add the disparities issues on top of that, right? Yeah. We have 38%, we Black women have our upwards of 38 to 40% of cancer mortality rates in the United States, but we're only 9% of the incidents. So that means we're getting caught late in the medical system. We're getting caught late in our insurance systems. We're getting caught late in our screening protocols. We're getting caught late. We've heard some of the challenges, of course, that we know routinely with respect to maternal health in this country. And we know at BWHI, if we talk about maternal health and we solve it for Black women, we solve it for everybody else, right? Like the maternal, we are on the list, 52 of 54 countries in the world. And we're at the bottom of that list in terms of maternal health in the world. And so we know that if we drive and address solutions towards thinking about maternal health outcomes measures and maternal health clinical solutions and support services for Black women, that saves all other women. And so I think the crossroads that we're in is really thinking about what are the policies and the systems that need to be in place to shift that, because now we're starting to see it's not just us, it's everybody. It's Black women first always, but it's all women now. And we need all women at the table to see that these are issues that are impacting them as well.
Love to add to the fact with Black women's health, it's head to toe. And we often talk about women's health in reproductive spaces. And so bikini medicine, right? Breast care, breast health and gynecologic health. And so for me, I'd like to add, we have to look at the full spectrum of health. Dr. Doe, you mentioned cancer. Black women and men are 40% more likely to die from colorectal cancers than any other racial group. As we're about to enter into March, it's Colon Cancer Awareness Month. And so research is really pointed that this is not really due to biology as much as it's due to access to high quality screening and care, catching the disease on time and early and having the best options for treatment. You know, for me, why it's urgent, this particular cancer took the life of my sorority line sister. She died at the age of 32 from colon cancer. And, you know, we have to do better. We have to understand what goes on in the bodies of Black women and what goes on in society that affects seeking and receiving care for Black women.
You know, if I can just throw my 2 cents in, I'm just reacting to your responses. I think I took 2 things away from that. One, Irene, what you just mentioned around the lack of access to high quality screening and care. I think it sounds like that's the prevailing kind of solve. And then what Ifeoma mentioned around, you know, if you solve it for Black women, you solve it for all women and for all people actually, and if you think about just the backdrop of Black History Month, you know, time and time again, Black people who have pushed progress forward in healthcare, it always came from a space of no one was taking care of us. So we had to, you know, innovate. We had to come up with a solution. One example is, you know, Freedom House, you know, the first basically EMT that was founded in Pittsburgh was founded by Black people because we weren't being taken care of when it came to being entered into the hospital. And so those are the 2 things that I'm coming away from that. Like, you know, the fact that even though we are feeling the brunt of a lot of the inequities, there is a drive for us to change, to fix things, no matter how the data is showing us, you know, in terms of what's happening in reality. So thank you for that. Irene, since you were the last one to chime in, I'd like for you to continue on, mention, you know, tying into scientific research, right? So if we think about, you know, scientific research and evidence, what are the most critical gaps in research when it comes to Black women's health? And how do those gaps show up in downstream in care innovation and outcomes?
The critical gaps are the fact that we need to broaden the investment in research. A major gap isn't that we don't know, we know the disparities. We know what is wrong. We have the numbers, 40%, 40%, 80%, 20% more likely, all of these numbers. However, there's not enough investment in solving these issues, in making sure that we are getting innovation to the hands of women. And a lot of these, I know we talk about access and care, but a major challenge, a lot of times you think Black women's health, health for Black people, and you think costs, or that they can't afford it, or that this is for a poorer population. Educated, wealthy, these health issues and these research gaps are extending across all kinds of demographics of Black women. And so I would say the biggest research gap is that we are not investing in solutions to the individuals that need them. We know what's going wrong, but we've documented, we need to scale. We need to scale in advocacy, we need to scale in our investments, and we need to scale in our solutions.
Thank you. Any other thoughts from the other panelists?
Yeah, I can add a little bit. I think some of the specific issues in terms of, additional gaps, we don't even have data, right? I mean, with very, very little data. So if you think about clinical trials that I do, there's such, underrepresentation of Black women. So how are we supposed to understand when a drug comes out, what's going to happen when a woman of color takes it, right? So that's a big, big problem. We also, when we think about not necessarily always clinical trials, but just more about sort of implementation and community-led research. We don't I think have enough of that, and we definitely need more. All of these things kind of ultimately then lead to misdiagnosis, delayed care, all of this other stuff, even higher adverse drug events, if you can imagine that. So, Black women, where there's anything that's worse for women versus men, it's always even more worse for women of color and Black women. So yeah, just so much to do there that, I think will help us as we think about innovation.
Any other thoughts from other panelists?
Yeah, the point that Dr. Garner is making about our underrepresentation in clinical trials is huge, because the solutions that come out of clinical trials tend to not work on us because we were not included in that. And we understand the sort of historical framing around that. We understand the fear. We understand the fear and the history. I mean, people don't want to say it anymore, but I'm going to keep saying it. The Tuskegee.
I do too.
And people forget that that's recent history, right? That's not everybody on this call knows about what that is. And we know that those sorts of historical framings are the reasons why there's this structural sort of tendency for Black folks not to want to enter into clinical trials, alongside the fact that we don't even get talked to about what they are. We never know when the clinical trial is coming. We don't get outreach to in the same ways that communities get outreach to. We don't get encouraged to participate in those studies. And we know that that is to the detriment in terms of what the solutions are that exist. I have a really interesting story about clinical trials that I always find really fascinating about how women get left out of the studies, right? And this is about seatbelt laws. And until about 10 years ago, the seatbelt laws and the testing around seatbelts in cars, everybody wears seatbelts. They used figures, the figures that they used to test the seatbelts were anatomically based on men. They were anatomically based on men.
Right.
And so we're built different. We have things in the front. We have hips. Right? We have like we have different bodies. But the seats that were seat belts were always tested on anatomically male figures. And so then you go back and you have to think about, well, how many more accidents could have been reduced or injuries could have been reduced if if we had just made that change in terms of testing. And I always find that really fascinating in terms of connecting that to what we do and don't know, right? Like we know what women's bodies look like. We knew that 10 and 15 years ago. So why wasn't that change made in industry? And so I think that is sort of like a real subtle framing around how we get left out of data and research all the time structurally is a really important note about how women get included in clinical trials.
So as someone who's not in the health ecosystem, only as a patient, and as a caregiver, it seems like it's a chicken and egg situation, right? So you've got we're not being included in trials, like there's no outreach. And then when there is outreach, there is hesitance from the community because validly there's been trauma, huge, I don't want to say mistreatment. Mistreatment is saying it mildly, abuse, right? And so how do we change that? And is that the role? And maybe this is leading to my next question, and maybe Beth or anyone else could take this on. Is this where representation matters, right? Making sure that we have more clinicians that look like us. Oh, excuse me, my light just fell over. More clinicians that look like us, more scientists that look like us, more, just from my own personal experience. I mentioned earlier, I had a very rough experience giving birth to my daughter, but a completely different experience with my son. And the key difference was I went to an all-Black hospital. I had it was completely different. And is that what we need to do? I mean, does it have to get to that point? I'd like to hear your thoughts on that.
Yeah, I can talk about that. And actually, before you even said that, one of the things I was going to say is exactly what you just said, which is we do need people of, I mean, and it's natural, right? You want, when you go to see a doctor, or when you're thinking about a clinical trial, you want to see somebody who looks like you. I mean, it's clear, right? So we definitely need, and we don't have enough at all, investigators out there, right? Who are trained and who are doing so. So there are some organizations that are focusing specifically on that to get, many more people of color, especially Black folks, to participate in clinical trials, and that then will start to bring in, their patients, right? And so that's critical, I believe. And I think thinking about this too, just one sort of piece to remind us is that FDA has actually put out, guidance for this, saying, you need to do all this stuff. The problem with that is that the FDA can't really enforce necessarily. So, you think about sort of the bigger companies that know that, they see the guidances and they're like, it's too much work, right? But if we can sort of bring to them, investigators of color who are trained, because I think that's also a concern is, when you're in a big company, you just want to go back to the same people, the same investigators every single time. So it's very hard to bring people in. But to be able to do that, I think is, there's a lot of work to be done, but it's critical, otherwise, I think with, just you said, I just don't think we can do it without having way more investigators who are people of color.
Right.
Dr. Gardner, that makes me think about the fact that when I speak to patients and we're thinking about just the relationship that you have with your patient, right? So helping them understand that this may not affect you right now, but someone in your family later on may be affected by this. And this is why it's important for you to get involved, right? So helping them understand you play a part in moving us forward. It's a relationship and we each are necessary to make the change that we want to see.
Totally agree. Yeah.
I think it's so important what you said, that representation, but also, if you want some numbers, Black women are 13% of the population, but less than 1% of full professors in science, in STEM fields, science, tech, engineering, math. There's been no increase in that number over the last 30 or 40 years. They're also less than 6% of physicians. So it's great. I love spaces like this. These are all amazing women. We're all Black women. Who else? If this is the number we're working with, we're not going to see solutions at the rate that we need solutions.
Right.
We have to increase our numbers amongst Black women, but also amongst people that are not Black, because if we're here to make sure that all individuals and that we really care about humanity, it can't just be Black women fighting for Black women. It has to be,
Yeah.
I love
you
that.
know, in that space.
Totally, yeah, totally.
That part.
Yeah.
That part.
Absolutely. Yep. I mean, I think one of the things, another sort of point that I had sort of jotted down is exactly that too, that we need to mandate basically, investigator training, because, women will, or women of color, whoever will go in and say, okay, I'm going to try this. And then they have a horrible time, right? And treated badly. They're never going to come back, right? So I think really, being just making sure that not only is there mandated investigator training, but we need to know what folks are doing, like who are the investigators that are serious, really just a no, cannot do this, right? Because that's a problem as well. So yeah, but totally, what you said, Irene, is clear and really important.
Well, it's shifting how society sees healthcare for women, just in general, right?
I think that's right. Yeah.
That thought process that, we're strong. Yeah, we're strong because we have to be strong, but we're afflicted with all the ailments that are out there as well. And so someone has to stand up for us. We're standing up for each other as women of color. We're standing up for all women, and men, chime in, jump in. Let's do this together because you need us and we need you, right?
Yeah.
So it's a partnership. Everything is a partnership.
Yeah, there's no woman in this country that should walk into a doctor's office being worried about whether or not her doctor is going to be able to treat her, whether or not he's male or female or whatever gender. We should just know that our doctors have enough training, wherewithal, the ability to answer our questions, from primary care to OB-GYN care to cancer care. They should know us the same way that they know men. That's it.
Yeah, and I've even heard, I forget who was talking about this around, medical school, right? We don't necessarily, when we think about who's coming into, to a medical school, we look at, their results in the, what's it, SAT?
USMLE.
SMLE. We look at, what have they done, scientifically, what publications we do all of that. But we don't actually do, sort of a check on, well, how do you, what are you like in terms of talking to patients, and we miss that. So we get a lot of people in who have no ability to actually take care of patients. And so I was hearing about, I forget where it was like, we need to have that piece of the story when we were bringing people in as practitioners, not just, doctors, but anyone who's going to be taking care of patients.
Sure. We address it too late.
Yeah,
that I can say.
Yeah, and then it's too late. You can't get rid of them.
Right. It's already ingrained.
Try to, train them, and So, yeah.
And would it make sense to include it as a rubric as part of their training, so they know? Oh,
it is.
Yeah,
it is. There's a whole course in that.
That's true, but what I'm saying is, don't even let them in.
Oh, I see.
Yeah.
How would you measure something like that? How would
There
you,
are
if when
ways
you
to do it? Absolutely.
there are ways to do it?
Tough.
Okay.
No.
Hard, but it could be done, I think.
Okay. All right. That's one takeaway. There's definitely one takeaway. Hey, I see a lot of questions in the chat. I forgot. I was remiss to remind everyone we are monitoring questions in the Q&A panel in the Zoom. So please, if you don't mind, and you guys can go wild in the chat, but when it comes to questions that we'll cover in the Q&A session later on, we'd like to have all the questions in the Q&A queue. All right. Sorry for that. Irene, you were going to say something. Were you going to jump in and say something?
I was going to say, circling back to what we were saying about the data, we need the data of women, but we also need the data from the leadership perspective at the table. And because in order to have the training that makes it into med school curricula, we need to know what's going on. We need those perspectives. And so we have to start valuing the perspective and incorporating it into those advocacy, into the curriculum, into the practice, the medical practice. Because if not, you don't know until you know. However, the data is ripe for the picking. And I did want to put in another plug for clinical trial inclusion, that we don't speak up enough about well individuals in clinical trials. And instead of just being the test group, we also need to be the reference group. And we have to get Black women in as a reference group.
That's an amazing point. That's an amazing point. We get lost out of both sides of this sort of thinking around what clinical trials drive in terms of solutions. We always get put in, if we get put in, on the side of being the ill patients, right? So I think that's a really interesting point in terms of, you know, measurability and scalability.
And it's an opportunity to get someone engaged when it's not so high risk and so scary. And so they can be introduced into this environment, to this type of activity and engaging in research when it's not my last resort. But now I can go in. It's a very different mindset. And I feel like it produces a different outcome and experience.
And just piggybacking on this concept of the pipeline and who gets trained and what they get trained in, we see that as well, not only for medical providers, but we see that for the researchers, right? So we know that 1% to 2% of Black people in the United States who ever get to the point of being able to get to a PhD level, there's not that many of us. There aren't that many of us out there. Like I see our MDs and PhDs on this panel. I know that there are people here, and I'm waving to y'all from afar because I'm like, hey, girl, hey, like they're nice to meet you, because there ain't that many of us out there. And so that pipeline around care, treatment, access, research, data, it's not inclusionary of us at those tables. And so we have to have allies. We have to have allies that want to ask the same sort of critical research questions and the same that are important for us.
So, Ifoma, on that note, right? So there's lots of organizations that talk about being committed to health equity, right? So what beyond the, mission statement and task forces, like what does meaningful action look like? Like what do they need to tangibly do to be able to live up to their credo?
Yeah, I mean, I think about I think a lot about the policy partners that I sit on coalition spaces with. The Sean Bertanis from the HIV world, HIV, the Ray Serranos from the Latino Policy Commission in DC. I think about our partners at BMMA, Black Mamas Matter Alliance, and our research partners who we're working closely with on AI work, the Data Justice Lab, who are researchers that are based at a university system who are really committed to AI and justice. And we know at BWHI that our mission is clear. Our mission is Black women. Our mission is the health and wholeness of Black women. But our mission has to be inclusive of whoever wants to listen to what that is, right? And whoever wants to be in space and community of what that is. I think about my team right now at BWHI, where when we plan our legislative visits, we're a nonprofit, so we have to be nonpartisan. But when we plan our legislative visits, we go knock on the doors of both Republicans and Democrats, right? We know it's whoever is an ally in our space across the aisle. We're coming to talk to you, and we have found that when we push on those levers and keep people engaged with us across the spectrum of our partnerships, whether or not they be at federal, state level, our coalition partners, our partners who care about cost and coverage, then when we move together in sort of symbiosis, then we know that we're not only addressing, again, the issues for Black women, but again, the issues for all communities that are facing these sorts of disparities. It's fascinating to me to think about policy levers right now in a time where policy levers are clearly jammed up, for lack of a better way of framing that. We're in difficult times, y'all, and I think everybody on this panel would appreciate and acknowledge that. We're in some really difficult and dark times. And we go. we still go to our Hill visits and we still talk to our representatives and our state people on both sides of the aisle, because someone on the Republican side is going to be very interested in hearing from us about maternal health, because they know that maternal health is an issue in their rural landscape as well. They know rural hospitals are closing, and
Yes.
they know that they can see that people don't have access to care, and they may sit in a very different political framework than me personally, but they know what they see that is happening to their people. And when we go talk to them, they're like, yes, this is an issue that's important to us. We see maternal health as an issue that's important to us because my reference hospital just closed, and now people in my district have to travel 75 miles to go have their babies or see their patients. And so those issues are important. When we talk about AI, AI is a huge sort of, people are
Yeah.
AI in the AI landscape, and we're also very worried about it as well. We're worried about it from the perspective of equity. 38% of Black households in the US South don't even have access to the internet. But here we are talking about OpenAI and Chat GPT Health, and we're supposed to all get our health information from these places. But 38% of Black households, I'm gonna say it again, don't have access to internet in the United States. And a lot of that fell out during the pandemic, where we saw kids being lost to care,
Mm-hmm.
lost to education because of that. And so I think that there's a lot of opportunities for thinking about levers in policy. And I love the question about measurement. So I'm going to stop talking, but don't get me started talking about HEDIS measures. Don't get me started. I will not stop talking about HEDIS measures. So I'm going to stop talking now so that I can come back to it, because HEDIS measures are a thing with regards to maternal health. So.
Mm.
Any other thoughts? No, I was fine with you. Normally you could keep cooking, but because this is important, right? When we talk about when we talk about health equity, right? And we're talking about, okay, what can we do to change? And the statement that it can't be just us has been repeated, throughout the panel. And so when I hear about what you said, you talked about having allies, advocacy, which is what women's health advocates is, which is what the Black women's health imperative is. Being, going to Capitol Hill, keeping the fire on, making sure that we have people with lived experience, talking to politicians and their legislative aides, so that we can push that agenda forward. And you were going to tease into measurement, but I was curious about that. Are you saying measurement in what sense? Is it measuring those, those organizations that tout on health equity and how they are actually performing against that? Having like organizations like Women's Health Advocates and Black Women's Health Imperative doing that? Like what that? Again, pardon me, I'm a newbie here, but what does that look like?
I'm going to pipe in just a little bit, and then I'm
Yeah.
going to bow down to Dr. Garner, who I know that this is his level of expertise as well. But a particular issue that we have been concerned about at BWHI and trying to sort of ensure that we continue in conversation is this idea that there are national quality measures that exist in this country that are directly linked to access and reimbursement, right? These are really complicated issues in the United States about how access to care, insurance coverage, reimbursement, payout systems, all of this is linked to a particular framework in the United States around measurement. And one particular area of measurement that we have been paying attention to a lot over the years are HEDIS measures. And there is one HEDIS measure in the United States that is focused on maternal health. Just one. there's just one. And the measure says that a woman after giving birth must be seen at least one time by her provider between 6 and like 67 days. It's some weird span of like access to care. Now, if that's our only national quality measure, and again, I'm going to defer to Dr. Garner because I know that she's been tracking these issues, then it's no wonder why we're losing Black women in the postpartum era, right? It's no wonder why we're not being able to see our birth outcomes be shifted and with regards to how we are cared for after we have babies, while we have babies. And so this idea that there are national quality measures that get set in the United States that are directly linked to reimbursement costs, directly linked to care measures, directly linked to cost and coverage, I think are incredibly important in terms of thinking about the levers and the spaces where science and data makes sense in terms of influencing policy. These are policy issues.
You said it. I have nothing more to add. Yeah, on point.
All right, thank you so much. So I just want to, this is our last question. I want to do a little rapid fire round robin before we hand it over back to Nada to do the Q&A. So what's one area?
Can I say one?
Sure, please.
Please do, Dr. Gardner. Don't leave me hanging. Please do.
Please.
I just want to give some uplifting thoughts too, right? So because I mean, people could, sort of come away from this going, oh my Lord, like anything happening that's good. And there are some truly, truly amazing women of color, actually, Black women who are really doing some incredible things. And so I'd love for just to be able to name a few just so that people can look and see what some of the amazing stuff is happening. There's a company called Mommy, that's this maternal infant, sort of platform to help everything that we've been talking about around pregnancy-related complications. There's Kindred, which is, I think, Brittany Braithwaite who put this together, and they have like a virtual clinic, right? That's incredible. There's the Ebony Women Health Corp that's doing similar things, and it is AI, yes, but really interesting. And then I think it's Kimberly Seals Allers. I don't know her, and I wish I did, because she has sort of put together this kind of a company that's called, or an organization, I guess I should say, called Birth Without Bias, which is just amazing. So there's a lot happening, I think, that's really, really, that's addressing a lot of what we're talking about.
You took my question out of my mouth.
Oh, really?
Okay. No, it's great. It's a great way to wrap up. I was going to say, what's the area that everyone's hopeful? Like, what are things that, we have this incredible panel, and we're just a small representation of all the great work that's happening, even with the challenges that we have. And we wanted this to be more, as we want to also recognize and celebrate, right? All of the great work that's been going on. So anyone else want to kind of share on that note around, areas that they're hopeful around, or things that they know that's work that's emerging or that's been released, or new work that's out there that's being led by Black people, or that's going to benefit Black women, that's out there that they want to share with the group?
Well, I know for us, I can even say, like, when I think about my institution, every room now has the objective pain scale. A lot of times, there was this misconception that Black women don't feel pain in the same way. And so, there was a delay even in labor in giving pain medication, or even post-operatively in getting pain medication. So just standardizing it objectively, and so this is what you need to do, and following that rubric, and also getting the patients more involved and helping them understand, speak up. Don't be afraid to speak up. Let us know exactly what it is that you're feeling, and also guiding my residents and my medical students to ask the right questions as well. And just understanding we are instrumental in providing the best care possible. It doesn't just happen by magic. You have to put in the work as well, and start at that level. And that's what makes you a great provider, who then continues to do great things for the community, not just the women, but everyone in the community.
Wow.
Thank you so much, Natasha. All right, so thank you. This was a phenomenal discussion. I hope everyone here who's joined in on the event took a lot of pearls from this. And so at this point, I'd like to hand it back to Nada. And I don't know, Nada, if we have lots of questions in the Q&A panel that you can run us through and see what's out there.
Yeah, we do. I was trying to feed them up to you, but you were so into the panel.
I was so into the conversation. Yeah, I'm in it.
Can I say this is awesome? Absolutely awesome. I mean, thank you. We as a people needed this. So I thank you.
Oh, I see. I'm in the Q&A panel now. I just clicked on it. Apologies. I was like watching everyone and just being in the conversation. So there's one person that said, this is from Sylvie Bello, can we have this panel at JPM 2026, where the investors are paying, funding, merging billions of dollars on innovation without us, then want to incentivize Black women with $25 for a clinical trial? So I think that's more of a rhetorical question, I'm thinking, but I think that's a sign of the fact that this conversation is needed, right? And is missing in the entire fabric, right? When we talk about healthcare. Any other thoughts from that question?
I'm just wondering if Sylvie's still on. I know she can't talk necessarily, but what do you do, Sylvie? What's your background?
Is she still around? If she's in the chat?
I think she just responded.
She did.
Oh, she's not. It's not rhetorical. She was. I guess you're.
No,
what do you do, Sylvie?
I think she's saying like we should
be on there, right?
Okay.
Yeah.
All right.
Yeah.
So I think this is part of what Women's Health Advocates is focused on, right? First of all, Ifoma, you said it right. We are bipartisan. You got to reach across the aisle. We got to work together. There's always an interest that someone has, right? It may not be obvious, but it's the power of storytelling. So Women's Health Advocates does that. Another thing is intentionality. We're very intentional about who we put forward as speakers. Here we actually went out. We're always about including people of color, women of color, and that lived experience. And I think everyone has to be intentional. So when I'm invited to speak on a panel, I'm always looking around who else. Sometimes I know I'm that N of one. They tick the box. They have their Black speaker, right? And that doesn't fly. It's a one step. But then I'm like, who else is on the panel? And if I can't make a panel, I will recommend at least 3 other speakers. Guess what? They're typically women, and they're typically women of color, starting with African American or African descent, and then Latinx, and then I move down the aisle, because we are the least represented group of people in leadership and on panels, and our voice is powerful and it makes a difference. So I think there's an intentionality piece, and we hear you about having better representation on panels, and that's where it happens. So Irene, I know you're unmuted, so please jump in.
To echo that as well. So you pretty much covered what I was going to mention.
Also, but yeah, so definitely hear you there. There's also a question about AI here, Erinkate.
Yeah, it says, is there an opportunity for AI to help improve institutions and systems to improve representation and health equity?
I think it can if it's used properly. Yeah. Right? So there's a lot more research and education that needs to go into AI and how you can mold it and fashion it to your field directly. I know it's already started to enter my field and area. Honestly, I don't think my residents have been trained yet. And so you're looking at what society is doing with it, and they're trying to just interject it into our daily lives and what we do. And I think it's at a detriment to the up and coming physicians. So there needs to be more education. And probably we need to get into that arena to learn about it so that we can then go back and teach them properly.
Yeah, I would agree with that, Dr. Fievre. I think that not only education at the clinical and sort of implementation of medical visits, but education in sort of communities as a whole. As I mentioned earlier, there's so many communities that don't even have access to routine internet access, and here we are asking people to go sign up for ChatGPT Health and use that as a proxy to find out what's going on with them health-wise within a context of a broken medical system where they can't even get access to care in some of those places. I think it also presents opportunity for thinking about the usefulness of it. We don't deny that there's a usefulness of AI in terms of the support practices for work. And then we also think about that there needs to be policy guardrails in terms of protecting people's information and how it gets used and how it gets put into these large language models, and how those large language models can be useful for care systems, but also need to have some guardrails around them. So we're deeply thinking about policy implications at BWHI with regards to Black women's health right now. We plan on releasing a white paper this summer to talk about exactly these issues. So.
And I think just adding on, there's a question from Cassidy, and maybe you can dig deeper into this, Irene, and all of you could answer. She's saying, how can we make women feel comfortable, and especially, I guess, here, Black women, feel comfortable either partaking in these clinical studies and providing their data regarding the history that some people choose to disregard, but is the reason why we have all these gaps in data. Maybe if you can give nuggets to folks as to why they should partake in clinical studies and how they can use their voice and the power they have. No one's taking your power away, right? But I think that ties back into what you were saying.
There's biology that is different between different individuals from different backgrounds, an environment that has shaped some of our epigenetics in how we respond to treatments, what goes in our body. And then there's a social aspect. Participating in trials is very important, but there's also a need for those that are conducting these studies to be very intentional about engagement and demonstrating transparency and authenticity about why you want someone to participate in a study, how it benefits the study and also how it benefits them, and then being very honest about the risks. Not every study has minimal risk, but we cannot assume that someone will not participate. And I think when we come in with more assumptions as a researcher saying they may not want to participate or this, instead of really looking at, if I'm truly here to help this group, I need to put every measure in place to reach that group, make sure they can retain, and even there was kind of the laughable incentives. The incentives need to make sense, right? Is the incentive that I need to make it a low load for transportation to get here? If I'm working, what happens to you working? If I need you to come for this trial and you have to come twice a week in the middle of the day, well, that doesn't make sense for certain communities, right? And so I think that intentionality is really important. And a lot of times researchers forget to share what they've learned back with the community that they got this information from. That means I see what you've done with my participation. I can now be willing to participate again and I can share it. That's the accountability that I think is being lost along the way. And so intentional in how we design a study, how we engage, making sure that we are doing it authentically and transparently, and then the accountability on the back end of circling back around and saying, this is what your participation helped us to do. And then at that point, you can even say, here's some additional gaps, engaging those various gatekeepers and women of color and leadership to say, how can we address these gaps? We got 20% of what we needed. When someone walks in, how could we get more, or what would it take? And I think that humility on the side of the researchers will really go a long way in making sure that we're inclusive, really, at the end of the day. Because if we're here to help all individuals, we cannot leave out Black women. We cannot leave out other color. We can't leave out the same way we don't want to leave out children or those that are elderly. This is another demographic. In considering there's so much history of Black women in this country, it doesn't make any sense that they're still being left out in the way that they're being left out without the care and intention to affect the change that we need to affect.
Amazing.
We are over time, Erinkate, and you're on mute, by the way.
Yes, I was just about to say that. I think the rest of the questions, I was just looking through the Q&A panel, they've been answered by us, by Beth and yourself. So I think we've covered all the other questions in the queue, and you're right, we're over. So I think we're ready to wrap up, if you don't mind.
Absolutely. Well, thank you all for your time. Thank you, panelists. This was truly insightful. I love spending space and time. The energy was needed. Great way to wrap up Black History Month. So first of all, the call to action is share this with others who may have not been able to join. This was recorded, so it'll be, if you registered, you'll get a link to the recording on YouTube. please feel free to join. Please feel free. No, don't feel free. Please join Women's Health Advocates. Your voice matters. There's a role for you. We have plenty of working groups. Maternal health was discussed here, but it crosses the spectrum. As Liz loves to say, we cover from head to toe. So there's something in there for you, and your voice is welcome, and your input is necessary and needed to help move the needle here for women. Feel free to share this and amplify it on social media. I saw folks talking about that in the chat. I also saw folks from across the pond joining us. So this is global, people in the UK, where there are worse health outcomes, especially in maternal health for women of color, especially Black women. And advocate for yourself. The best part of Women's Health Advocates, if you want to reach out to your congressional leaders, your senators, there's links in there for specific issues where you can just put in your name and your zip code and either tailor the letter for what you want to say, make it personal, but it's already drafted for you and you press a link. I've done it several times. I know many people have done it, but it's really does help elevate our issues to those in power that can influence where money is placed and where the priorities are led. And also join Black Women's Health Imperative. I've put links throughout the chat to all the websites that you can partake in and resources. And join us. We'd love to have you. And thank you. Thank you so much, everyone.